ideia é que possamos, durante essa manhã, fazer o lançamento do Manual de Qualidade em Saúde. De forma muito breve, a ideia da Anahp, em parceria com acreditadoras e com empresas que trabalham no setor, a ideia é que se possa fortalecer a divulgação dentro do setor de saúde sobre a importância da acreditação como uma ferramenta fundamental para a defesa da qualidade. A acreditação não é um selo que se coloca na porta de uma empresa do setor de saúde. A acreditação é uma decisão de cada hospital de rever os seus processos, de rever a forma como se organiza e, a partir daí, oferecer ao paciente aquilo que é o dever ético e legal dos prestadores de serviço de saúde, oferecer qualidade e oferecer segurança. A nossa reunião vai ter duas etapas. Na primeira, vamos ouvir breves manifestações de cada um dos representantes dos diversos atores que trabalham no campo da acreditação. E, no segundo momento, com muita honra, vamos ter a presença do Dr. Carsten Engel, que é o CEO da ISQA, ou seja, o presidente da principal entidade mundial para qualidade em saúde. Começando, então, vamos pedir a primeira manifestação, em homenagem também às mulheres, da nossa Aléxia Costa, diretora técnico-científica do Grupo IBES. Aléxia, por favor, bom dia.
Bom dia a todos, bom dia aí, boa noite aqui, que eu falo diretamente da Austrália, mas representando aí o Grupo IBES e hoje representando a metodologia AXA de acreditação. Bom, dou aí os parabéns a todos os envolvidos e especialmente a toda a alta liderança da Anahp, né, pela ideia muito importante de trazer esse manual à tona, disseminá-lo aí a todos os interessados, não só para aqueles que são membros, mas inclusive de forma aberta a toda a população e todos os hospitais e outras organizações de saúde. Vivemos, como todos sabem, uma época de crise bastante crítica, né? Temos aí guerra, temos pandemia que ainda não se encerrou, aumento de casos no país, inflação, né? Damos aí as boas-vindas novamente a um momento que vivemos aí na última época do Sarney, e a era agora é de inovar, cortar custos, né? Rever processos e trazer melhoria de performance para as atividades que a gente realiza, né? Seja assistenciais, administrativas ou de apoio. Então, guias como esse trazem à tona roteiros a serem seguidos, trazem ideias, trazem opções, inclusive de acreditação, para aqueles que ainda não incorporaram o tema, né? Sabemos aí que apenas 7% dos hospitais hoje são acreditados no país, e trazer o tema para as políticas públicas e para as discussões de entidades de classe, e todos os momentos em que a gente tiver essa chance, né, como agora, é de extremo valor. Então, agradeço aí, Antônio, pela oportunidade da palavra, pela oportunidade de participarmos desse manual, e vamos em frente, e peço a todos aí os presentes que nos ajudem a compartilhar o material mais e mais. Muito obrigada.
Muito obrigado, Aléxia, muito obrigado. Passo, então, para a Ana Carla Labigalini, que é diretora de acreditação e desenvolvimento da Health Hub Accreditation. Ana, por favor.
Bom dia a todos. Com grande honra, nós estamos aqui junto à Anahp. Primeiro, parabéns a toda a diretoria da Anahp por esse projeto que é fundamental hoje para as instituições de saúde do Brasil e dar todo esse suporte, esse apoio, inclusive para direcionar essas instituições através de um guia, né, desses padrões, para que elas consigam melhorar os seus processos, alcançar outros resultados. Hoje nós sabemos da dificuldade que é, porque apenas 7% dessas instituições buscam um processo de acreditação, e a ideia realmente é essa, é ampliar, não só para que tenha um selo, né, como o doutor Antônio Brito trouxe, não só um selo, mas que realmente mudem os seus processos e que tragam melhores resultados, não somente ali para a instituição, mas por todo o ecossistema que está ao redor dessas instituições de saúde. O diferencial é nesse modelo de gestão e resultados.
Muito obrigado, Ana, pela sua manifestação. Eu passo agora para uma manifestação inicial para o nosso Eduardo Ramos Ferraz, que é o coordenador de Healthcare da Det Norsk Veritas, a DNV.
Bom dia a todos, eu agradeço aí a Anahp pelo convite e pela oportunidade. Eu gostaria de dizer da importância da iniciativa, né, de oportunizar para que todas as instituições acreditadoras discutam e coloquem os seus posicionamentos sobre o valor da acreditação, né, como o doutor já disse, não só como um certificado na parede, mas de fato que ele cumpra o papel dele para a segurança do paciente, para a sustentabilidade das organizações. Né? A gente vê muito a importância dos sistemas de gestão das acreditações. Quando a gente viveu aí a pandemia, né? O quanto que esses sistemas eles colaboram para a continuidade dos processos e para que essas organizações elas tenham fluidez aí mesmo vivenciando riscos emergentes. Tá? Muito obrigado.
Muito obrigado, Eduardo, também pela sua manifestação. Vamos passar ao nosso Heleno Costa Júnior, que é o superintendente do Consórcio Brasileiro de Acreditação, CBA.
Olá, bom dia a todas, a todos. Aí queria também, na figura do Antônio Brito, agradecer aí a liderança da Anahp. Eu acho que a gente tem uma oportunidade muito especial de iniciar esse movimento. Isso era uma questão que a gente tinha como ainda um vácuo, um espaço diante da sociedade como um todo, não só das instituições de saúde, de levar mais informações e esclarecimentos sobre essa questão de uma ferramenta, de uma metodologia, né, que pode ser citado, que, na verdade, vem em favor de um grande beneficiário dos nossos sistemas e serviços de saúde, que é o paciente, portanto, levando aí grandes ferramentas para que a gente possa, de fato, avançar com a gestão da qualidade, mas, fundamentalmente, com a execução de uma assistência mais segura, olhando, por exemplo, o elemento principal disso tudo, que é o desfecho clínico que chega até o paciente, e a acreditação permite, de fato, esse movimento em direção a essas conquistas. E acho que esses esclarecimentos, né, essa oportunidade, como essa cartilha que hoje vai ser lançada, de fato vai ocupando esse espaço e nos permitindo, então, ter mais clareza daquilo que é a proposta, o objetivo, mas, fundamentalmente, os benefícios de um programa de acreditação, além somente da questão de um selo, né, de uma lógica final, mas dos benefícios. Então, aí, parabéns à Anahp e a todos nós que estamos aqui nos organizando nesse movimento. Muito obrigado.
Foi muito interessante o Heleno referir a palavra movimento, porque é exatamente isso. O manual que nós estamos lançando, ele é apenas um instrumento de trabalho para que a gente possa percorrer mais uma vez as autoridades, mais uma vez todos os hospitais brasileiros, mostrando a importância, eu diria até do ponto de vista ético, o comprometimento obrigatório dos prestadores de serviço em saúde com a questão da qualidade, simplesmente porque ela é premissa para que se possa respeitar o paciente, finalidade maior de tudo aquilo no qual nós estamos envolvidos. Passo a seguir, com muita alegria, também ao Péricles Góes da Cruz, que é o superintendente técnico da Organização Nacional de Acreditação, a ONA.
Bom dia, Antônio Brito. Inicialmente, o meu agradecimento pelo convite, por essa participação. Meu agradecimento também à diretoria da Anahp, porque a ideia inicial, como você mesmo nos disse nas primeiras reuniões que tivemos, é agregar todos. Afinal de contas, o nosso objetivo é um objetivo comum, trazer cada vez mais segurança ao paciente, garantias de qualidade, o maior número possível de informações e orientações a esses usuários do serviço de saúde, para que eles possam entender aquilo que lhes é oferecido e, da mesma forma, também para as organizações de saúde, cada vez mais buscarem melhores processos de gestão, voltados para a qualidade, voltados para a segurança. Quando a ideia desse manual, dessa publicação, foi lançada, foi exatamente essa de colocar um panorama geral do atual cenário, né, em que a qualidade hospitalar, das organizações de saúde, de uma maneira geral, está colocada, né? Nós temos aqui representantes de importantes organizações que estão voltadas fundamentalmente com o objetivo de melhorar a qualidade da saúde no país. Indiscutivelmente, todos nós, cada um com sua metodologia, mas todos com um objetivo comum, garantir para que o paciente tenha um atendimento de qualidade e garantir para que as organizações de saúde tenham melhores processos de gestão. A publicação também vai fazer com que diversos participantes dos diversos setores possam entender o que é um processo de acreditação dentro de cada metodologia, buscando, evidentemente, aquilo que você, Brito, mencionou, que não é apenas um papel, um certificado pendurado na parede. Muito mais que isso é o que está por trás da parede. São os conceitos que as organizações de saúde absorvem no sentido de proporcionar melhor qualidade a esses pacientes. Essas informações, elas, dentro dessa publicação, elas estão bastante transparentes. As informações, eu observei que elas são objetivas, claras, sem muito detalhamento técnico. Isso faz com que essa leitura seja uma leitura leve, mas de uma compreensão profunda do que são as diversas metodologias de acreditação. E eu entendo que, sem dúvida nenhuma, esse manual vai ajudar muita gente para alcançar novos caminhos voltados para o processo de acreditação. E, ao mesmo tempo, como você disse muito bem, para que possamos cada vez mais, junto às autoridades do país, buscar um entendimento no sentido de ampliar todos esses processos, fazendo com que a saúde no país possa ser a melhor possível. Mais uma vez, obrigado pela participação, obrigado a todos os colegas pela dedicação e pela participação em todo esse processo.
O Péricles salientou o fato de estarem todos reunidos aqui, e esse é um objetivo importante também, que aqueles que se dedicam à questão da qualidade, ainda que organizados em diferentes empresas ou em diferentes movimentos, possam também estar juntos na defesa dessa tese tão importante. Eu chamo agora e convido com muita alegria a manifestação do Carlos Irã Góes de Souza, que é membro, desculpem, da AACI Brasil-Portugal. Carlos, muito prazer em recebê-lo.
Muito obrigado, Antônio Brito. Obrigado, Anahp, por essa oportunidade de participação. Hoje eu falo de Coimbra, aqui de Portugal, e é com muita alegria que eu vejo os rostos de pessoas queridas que participaram dessa história no Brasil, parte dessa história no Brasil, e que, naturalmente, me é muito grato sempre revê-los, né? E essa oportunidade que a Anahp nos proporciona é mais um marco nessa história, né? Uma história que já vem lá de 1917, 18, né? Se nós nos situarmos lá nos primórdios da história da acreditação, e se nos situarmos dentro dos primórdios da acreditação como conhecemos hoje, né? Um pouco menos, 1951 para cá. Então, eu diria que, ciclicamente, a acreditação vem mostrando todo o seu poderio e as suas oportunidades através desses movimentos cíclicos. e a ANAP ela registra, nesse momento, um rito de passagem no momento em que estabelece esse manual, né? Até porque essa cartilha é uma manifestação muito clara daquilo que vem se discutindo há uns 5 ou 6 anos para cá sobre a literacia em saúde. É importante que nós possamos utilizar esse tipo de metodologia com mais clareza do que complicações semânticas, não é? Então, de forma que as organizações de saúde possam entender claramente esse processo que vem galgando espaços ao redor do mundo, como todos sabem, e que o Brasil tem momentos, marcos muito importantes para esse movimento mundial. É com imenso prazer que eu estou aqui representando como vice-presidente da ACI América e como diretor de desenvolvimento de padrões da H2A, mais recentemente inserido no processo a convite da Dona Carla, e que esperamos fazer também, dar uma contribuição maior a todo esse processo brasileiro. Muito obrigado, prazer imenso. A ANAP, meu bem-aja, e, sobretudo, que seja um sucesso diante de todos os hospitais que fazem parte da vossa associação. Muito obrigado, Péricles, Heleno, Rubens, Aléxia, Eduardo. Prazer imenso estar com vocês hoje.
Muito obrigado, Carlos. Nós somos, nesse momento, 270 participantes nessa reunião, de hospitais da ANAP e fora da ANAP, de pessoas que acreditam em qualidade e querem desenvolver qualidade no sistema de saúde no Brasil, público ou privado. Repito, o manual é apenas um instrumento de trabalho. O importante é estarmos juntos e, para a ANAP, essa é uma questão absolutamente central na nossa agenda, conforme a orientação do nosso Conselho de Administração. Para concluir essa primeira parte da nossa reunião e passarmos, então, ao Dr. Carsten Engel, eu passo com muita satisfação a oportunidade de falar ao nosso Rubens Covello, que é CEO da Quality Global Alliance, QGA. São muitas, vocês gostam muito de siglas. Então, temos aqui agora a QGA. Caro Rubens.
Olá. Que bom estar aqui, né? Que bom estar aqui, Péricles, Heleno, Carlos, Aléxia, com mais de 270 participantes. Que coisa fantástica. Eu acho que há muito tempo a gente não juntava tanta gente para estar falando de qualidade e segurança, né? A ANAP sempre foi pioneira nesse processo, né, de acreditação. A ANAP foi pioneira há muitos anos atrás, quando definiu que, para ser participante da ANAP, a instituição tinha que ser acreditada, né? E a ANAP, dessa maneira, desenvolveu um primeiro passo em relação à questão, o primeiro grande passo em relação à questão de acreditação nesse país. Acredito que 100% dos hospitais que hoje estão na ANAP são acreditados. Em contrapartida, em torno de 7%, 6%, 5% cada dia. E tem um número sempre muito baixo de instituições do Brasil todo que não são acreditadas. Eu quero agradecer muito o Brito, né, e dar os parabéns para ele e para o grupo da ANAP por esse desenho pioneiro, por esse movimento e por esse manual que eu consigo entender que ele é um manual de sensibilização do processo de qualidade e segurança, né? Esse manual ele é uma base de sensibilização em relação ao que nós queremos fazer com o sistema de saúde como um todo. Todos nós aqui entendemos que a acreditação é uma ferramenta de transformação, né? Tanto das instituições de saúde, mais que isso, dos sistemas de saúde como um todo, né? E aí assim, é muito legal estar aqui mesmo com todo mundo e muito bacana, Brito, entender que o posicionamento da ANAP agora não é para dentro da ANAP, é para fora da ANAP, é out, né? Nós estamos procurando o Brasil inteiro para, com este manual, que eu agradeço por ter contribuído, junto com todos os nossos colegas na construção, que a gente sensibilize as instituições, que elas entendam exatamente o que nós estamos falando quando a gente fala a regra básica. Vamos colocar o paciente no centro. Muito obrigado, Brito, obrigado aos colegas, e vou ficar por aqui ouvindo o meu amigo Carsten.
Muito obrigado. Nós vamos passar, logo depois desse evento, a fazer a distribuição online, o acesso absolutamente aberto a tantos quantos desejem acessar este manual. Vocês têm aí uma primeira visão já do manual, e ele vai estar disponível no site da Anahp a partir do encerramento desta reunião. Ele já pode haver o download. Se me permite, eu vou agora fazer uma pequena saudação em inglês ao Dr. Carsten Engel. It's my pleasure to introduce Dr. Carsten Engel. He leads the global movement for quality as president of ISQA. And if you allow me, Dr. Carsten, I would like to add...
Good afternoon. Can you hear me?
Yes, we are hearing. If you allow me, I would like to add that that's for Anahp, our main goal and our mission. More than 85% of Brazilian hospitals with international accreditation are our associates. However, we are not satisfied with these figures. We need to improve the quality movement in Brazil. The introduction of this document seeks to defend and demonstrate the extraordinary achievements the accreditation process can bring to Brazilian hospitals. Dr. Carsten, it's a great honor to have you here with us, and it will be of immense pleasure to hear from you now. Dr. Carsten, please.
Good morning to everyone, and thank you for the opportunity to talk to you about this issue, accreditation. How can hospital benefit? That's very close to my heart. As you've heard, I'm Carsten Engel, CEO of ISQA. ISQA is based in Ireland, but I'm talking to you from Denmark today because that's where I'm based. First, a few words about ISQA. ISQA is a global membership-based organization with individual and institutional members all over the world. Our individual members have both healthcare professional and other backgrounds and include many researchers. Many of our institutional members are accreditation bodies, but membership also includes other types of organizations, typically institutions that in one way or another facilitate the work of those that directly provide healthcare services. Our vision is to be the global leader of transformation in healthcare quality and safety for all. And our mission is to inspire and drive improvement in health and the safety and quality of healthcare worldwide. Knowledge, evidence-based knowledge on how to support, promote, and improve safety and quality of healthcare is at the core of everything that we're doing. The International Accreditation Program was established in 1999 and has been an important part of the ISQA package ever since. We have worked with around 70 organizations in 34 different countries. ISQA, or in fact, actually its subsidiary, ISQA EEA, does not directly accredit hospitals or other service providers. What we offer is a third-party external evaluation service to accredit the accreditors. We have a team of about 90 international peer review surveyors who do this on a voluntary basis. These individuals are based all around the world and are experts in the area of standards development and external evaluation. There are different program types. One is the assessment of healthcare and social care standards. The second type is the organizational survey, where the governance, management, and operations of an accrediting body are assessed. And the third survey type is the assessment of surveyor training programs. So ISQA EEA, through the International Accreditation Program, sets quality standards for all aspects of accreditation and assesses accreditation bodies based on those standards. As you can see, we are present in all parts of the world, and in Brazil, there are actually 6 organizations that have one or more of the ISQA accreditations, and that's the Brazilian College of Radiology, the Brazilian Society of Clinical Pathology, the Fundação Carlos Alberto Svanzolini, the Instituto Brasileiro para a Excelência em Saúde, the Health Services Accreditation IQC, and ONA, the Organização Nacional de Acreditação. And you can find all our accredited bodies all over the world on the ISQA website. Why would you want to go for accreditation? Well, it's nice to have a stamp of recognition, and obviously accreditation is a sort of stamp, and it's a stamp that I think is valuable to have, but don't go for it to get a stamp. If a CEO tells the chief quality officer to get the hospital accredited, but please don't bother me meanwhile, then there's a considerable risk that you waste time and efforts. You may get the stamp. If your chief quality officer is diligent and persistent, it's even likely that you will get it. But if you treat accreditation as an add-on, a project not connected to how you otherwise lead and manage the hospital for no other stated purpose than getting the stamp, you risk generating frustration, duplicating efforts, even launching conflicting efforts, and making things for appearance rather than for real change. A managing director from Joint Commission International Europe summarized this very well back in 2008 when accreditation was about to be launched in Denmark as an advice to us. If the bureaucratic approach is prevailing, much energy will be used to demonstrate formal compliance with standards, but there will be no real willingness to change and improve patient safety. But on the other hand, if the top leaders embrace accreditation as part of their leadership and management strategy, understand what they're doing and why they do it, are able to communicate it throughout the organization, and allow middle and frontline managers to find the meaning of the standards and the way to meet the standards in cooperation with the frontline staff, then accreditation becomes a powerful tool that helps you do what you want to do and is not an extra burden. This does not mean that it doesn't take effort and resources to become accredited, and there are of course costs associated with the accreditation survey itself. There's no need to deny that. The question is, what's the return? We can't find much about that in the literature, and what we find confirms that it's hard to quantify in monetary terms both costs and return, and that's mainly because everything is so entangled with what you otherwise are doing, so it's different to sort out the warm water portion of what's in the bathtub, so to speak. Accreditation may reveal opportunities for improvement that you want to make use of, or even gaps that you will need to fill. That may lead to costs, but you can hardly blame the tool for these costs. On the other hand, I'm also convinced that you will find opportunities to reduce waste by creating more order and efficiency, reducing complexity, and finding opportunities to avoid harm and all the costs associated with harm. Preventable harm is a particularly painful type of waste. I am aware that the savings from avoiding harm may not benefit the hospital directly, but that's another story. And by the way, if you take this approach, you will get a certificate and you will have deserved it, and it will be a demonstration of real value added to your organization. One of the things is that obtaining accreditation will enhance your reputation. It can help you getting public contracts. It can help you establishing good relationship with insurance companies. If you are in the business of medical tourism, it's a way to demonstrate to prospective travelers that you can deliver what they want, and it can also help you attract staff who wouldn't rather want to work at a place that has demonstrated that it can deliver quality than in another place. Okay, this was something about the why. Now we need to discuss a little bit, what is it really we're talking about? What is accreditation? Well, let's begin with a closer look at the purpose. from its very beginning 100 years ago. Yes, it did originate 100 years ago in the United States. But during all this time, the motivation has been a desire to promote and support a consistent level of quality of care. This is what we call quality assurance. It is achieved by assessing whether the organization meets defined and published standards. These standards describe where you are expected to be. But since the beginning, quality improvement has become an additional important objective. This can be pursued by using stretched standards. Stretched standards describing where you are not yet, where you should not be yet, but where you want to be tomorrow or the day after tomorrow. Standards can also describe how you plan, execute, monitor, and evaluate your quality improvement work, and in that way, guiding your improvement journey. So you can both set the aims for your improvement journey and guide the way in which you travel the improvement journey towards aims set by others or defined by yourself. The basic principle behind accreditation is that the predetermined requirements are phrased in a way that allow hospitals to assess either by themselves, that's what we call self-assessment, or as a result of an external survey, whether they meet them, and allows hospitals to determine, and also allows hospitals to determine what to do if not. In other ways, you determine if you meet what you are required to meet, and at the same time get information on where the gaps are if you are not. So the standards express the prerequisites for achieving the desired outcome, what is needed to achieve a consistent level of quality of care and to succeed with continuous improvement. And if gaps are related to current requirements, we may talk of closing gaps relative to expectation or quality assurance. If gaps are related to stretched standards, aspirational standards, identification of gaps will inform quality improvement. We can be a bit more precise about the components of accreditation if we take as guidance this definition of external evaluation taken from a terminology paper published by ISQA, and that can be found on the ISQA website. I won't read all of this out for you now, but you can see there are a number of characteristics, and this is what all accreditation programs will meet. And some of the key things running through this is transparency, objective mechanisms, and a defined methodology. An accredited hospital should have a defined, systematic approach to what we call Durant's triangle: quality planning, quality control, and quality improvement. Quality planning is how you establish quality goals at an organizational level, but very importantly, also cascade them through to the teams working at the clinical front line. It is also about identifying client groups and their needs, and then plan service design based on these needs and the quality goals. Quality control is about determining how the hospital will monitor if actual performance meets requirements and ensure that deviations are identified and corrected. In other words, how it maintains control of the quality. And quality improvement is a consistent approach to systematically improving the way in which care is delivered to patients and family. Quality assurance, on the other hand, serves to verify to external parties that control is maintained, also verified as part of your accountability requirements, source reports, for instance. Quality control and quality assurance, importantly, do not mean that we should measure and document everything. That's a common misconception. We should only measure and document as needed to maintain control and establish assurance. Furthermore, it's very important that quality control should be performed close to the process and in real time, whenever possible. Those who deliver services should be able to monitor the quality themselves and adjust immediately when required. The best way is not to have someone control what I'm doing. I and my team should control what we are doing and use the input from the control to continue to produce as expected. So There are two main components of an accreditation program. There are the standards that conventionally are classified as addressing structure, process, outcome, or culture. And then there's an evaluation methodology by which compliance with standards is assessed. For an external evaluation used as a basis for issuing, or in some cases denying issuing, of a certificate, a stringent methodology is mandatory. When an organization assesses itself as part of the implementation of the standards, the focus is on identifying gaps and to plan improvement activities, while an exact rating on a scale is less important. Now we'll take a closer look at those two components. So the first question is, if we sign up for accreditation, what kind of standards would we be assessed against? Structural standards describe requirements for the framework within which the hospital and the hospital staff operate. So typically, structural standards describe the minimum of basic conditions for safe care and are related to quality planning and quality control. There are several types of structural standards. There would be standards for infrastructure, for instance, that would both include physical infrastructure, but also the planning infrastructure, such as the safety plans, emergency and disaster plans. There would be standards for organizational structures, which would include demands for clear descriptions of tasks and responsibilities, who is responsible for doing what, whom are they accountable to, etc., etc. There will be standards for governance and management, which include providing clinical guidelines, providing safe environment, having an ethical framework and guideline and channels of communication, so that we are clear about what it is we want to do, and we have the tools to help us doing it. And finally, an important component of structural standards would be standards for staffing, which would require you to have appropriately qualified staff. They could address some things such as nurse-to-patient ratios and training in things like advanced life support or any other kind of training for staff. You should notice that structural standards tend to be dichotomous. Either the organization meets them or not. But then there are process standards. They describe requirements for what's actually going on within the organization. They describe the mechanisms that organizations use to enhance safety and minimize risk. And key principles are that processes are fit for purpose and are performed right the first time. The standards can be generic about how organizations collect data, monitor performance, compare expected outcomes, forecast future performance, and initiate actions to prevent adverse events and near misses. But they can also be more specific and related to patient safety teams, such as infection control, medication safety, correct patient identification, and false prevention. So we will find standards that address leadership, actual care processes, supportive processes such as procurement procedures or human resource procedures for skills trainings, and some standards that address specific aspects of themes across processes, for instance, person-centeredness, which has become a very important theme when we're talking about quality. Process evaluation is usually the main part of an external evaluation. Processes can be viewed from different perspectives. There can be a conformance perspective. For some processes, there's a best practice, a way of doing it that should be rigorously followed. How you set up a blood transfusion, for instance. There's a very clear process for that that should be followed every time. That's very well suited to be phrased as a standard. But then there's an outcome-oriented perspective. Is this process designed in such a way that it's likely to achieve the desired outcomes at organizational or individual levels? Is the system able to adjust the process properly in response to changes in the input and the environment? And then there's the capacity and capability perspective. Does the system have the resources, leadership, support functions, and culture that will make the desired performance likely? Is there clarity about goals and about the means by which these goals should be achieved? What do we mean when we talk about the quality and the capacity and capability perspective? And here you can see all these aspects that will be assessed: the competencies of those that make the decisions, the existence of deployment of relevant and clearly defined policies, a transparent and understandable operational plan aligned with the strategy, effective channels for communication with timely access to relevant information, presence of fora and opportunities for consultation, shared decision-making frameworks. Then there's the provider's own control of quality of decisions, which can be built into the process or can be executed through audits. And finally, there can be different kinds of support for decisions and execution of decisions. The ultimate outcome of healthcare is population health compared to accepted targets. Are we achieving what we should achieve in terms of outcome? That will be the ultimate test. A comparison over time to predetermined objectives, thresholds, or best practices is needed to be able to evaluate the outcome. Comparison with other organizations will add perspective. Do we achieve what your peers are achieving? The outcome is generated through a multitude of intermediates, some of which can be measured by numerical methods, for instance, door to needle time for stroke thrombolysis. This is an example of a process measure that is closely coupled to an outcome measure, whereas other measures are more suitable for qualitative assessment, safe medications, for instance. These are procedures that are not easy to measure by numbers. So in many cases, you are not able to measure the final outcomes because there may be a time delay from the action to the outcome, but instead you then choose to assess some intermediate outcomes as the door to needle time. We need to be aware that standards should recognize that health is influenced by factors beyond the control of provider organizations. So improving health requires a system-wide approach, reaching beyond the borders of healthcare providers. And in addition, you could take the approach that not only the outcome itself, but also the way in which the organization monitors and reacts on the outcome it delivers could be said to be a way of an outcome-focused standards. So we would then ask about the planning and controlling cycles, what processes are in place to determine outcome measures and their goals. Are you and your staff clear about what you want to achieve and what you actually do achieve? And finally, there are culture standards that describe the mechanisms organizations use to initiate and follow up on improvement interventions, to learn as a team, to solve problems, and to involve their clients and their relatives. The focus is on the organization's attitude to change and the connections between strategy and daily activities. Tools, questionnaire surveys exist and can be used to assess different aspects of culture. But culture is typically harder to describe in terms of defined and specific requirements than structure, process, and outcome. This graph illustrates the journey of a hospital over several accreditation cycles. It shows that within the first 2 cycles of accreditation, structures are built and processes have been put in place, leading to planning and controlling quality management. When evaluating an organization or in future a patient journey over a long period of time, one sees that when reaching a higher level of maturity of the quality management system, outcome measures also tend to improve. When the organization becomes more and more experienced in building effective structures and processes, better and safer care can be delivered. In the third cycle, being assessed and standards focusing, in the third cycle, quality is being assessed and standards focusing on outcome are generally being met. The flattening curve shows that over the same period of time and with the same effort, the experienced added value decreases. And in the fourth cycle, all efforts go into maintaining what's already in place. But now a culture that supports innovation within a learning organization can help reach new levels of continuous improvement and leading a new rise and ramp cycle. So much about standards. How would we be assessed then? Structural requirements are usually dichotomous. Either they are met or they are not. For process requirements, it's different. Processes may be uniquely described, but they are repeated numerous times every day, and in practice, execution is variable. Any assessment of a process is conducted at a particular moment and in a particular place involving particular persons, and there's no guarantee that the next assessment of the same process will generate the same result. Therefore, the final evaluation is based on multiple assessment and uses triangulation where the same process is studied by different methods. Typically, surveyors would look at the specification of the process in the manual. They would observe how the process is carried out in an actual care situation, if possible. They would review documentation of processes, for instance, in patient records. They would do interviews with staff, asking them to describe or demonstrate the process, and they will do interviews with patients and families to collect their experience. They would look for, first, the design of service delivery, or what you might call work as imagined. But then they would also look about actual service delivery, you might call that work as done. They would look at service experience, and they would assess the gaps between those three. I introduced to you the concepts work as imagined and work as done. These are important concepts that you will also meet in the literature on resilience and complex systems, and in some literature on safety, notably on the concept safety too, but unfortunately time does not allow me to dig deeper into this. But work as imagined refers to the various assumptions that people have about how the work should be done. Typically, work as imagined can be written down as procedures, but also in many cases, people have a picture in their mind of how work should be done. But then when you actually do it, something may come up that prompts you to do it a little bit different. Sometimes that could be considered an error, but in a complex system, it can also be a desirable adaptation to particular circumstances or adaptations and improvements accumulated by experience, but still not reflected in work as imagined, because work as imagined is also something that will develop as the organization improve its service delivery and also its concepts about how service should be delivered. But the essential thing is that in a complex system, you can't predict everything that could happen, and sometimes you will have to modify your procedures in order to get the result you want. Everyone who has treated a patient according to clinical guidelines will know what I'm talking about. Okay, how can we then make accreditation work for us? To achieve safety, there are a number of strategies we could choose to follow. And Vincent and Amalbertis, in their book Safer Healthcare Strategies for the Real World, summarize this very nicely. One of the strategies is to follow best practice in cases where there is a defined best practice that you should follow. In some cases, we know that if you do this, you will get that outcome. Unfortunately, that does not apply to everything we're doing. Another way of achieving safety is to improve working conditions and organizational practices, removing disturbance, reducing complexity, making it simple to make the right choice. For instance, by using checklists and structured handovers, training of staff, reduction of noise and disturbance, better working environments, and improved levels and organizations of staffing. We should also enforce risk controls where that's possible. We could build in technical constraints that only allow us to do the right thing. We could restrict certain procedures to specifically privileged organizations or professionals, or we could define no-go conditions. For instance, you would not continue with a procedure that requires general anesthesia if the patient has an acute upper airway infection. Then there's the monitor, adapt, response thing. I'll return to that in a moment, but we should not forget that sometimes risk is unavoidable or may be accepted, but we must then establish mechanisms for mitigation of harm if harm occurs. Some of these are readily translated into standards. That's the one about standardizing processes, improving working conditions, risk controls, and harm mitigation mechanisms. But what about the fourth one, building capacity and capability to monitor, adapt, and respond? What are we talking about here? In settings where care can be precisely delineated, we will not need these things. But in more fluid and dynamic environments, we must be able to monitor and adapt. Although all environments require a solid procedural underpinning, we need to have somewhere to start. You have a work as imagined as a starting point, but sometimes you need to modify it because of this or that. And how can we build capacity and capability with this into our systems? Team building and promoting good team culture are key. One example of a practical approach could be to build team briefing where anticipations and options are shared into clinical routines. And this is something that could easily be translated into a standard. Another strategy would be developing ways of predicting variations, for instance, times of staff shortages or times of high influx of patients. While some harm is caused by extraordinary or unpredictable events, many would say that much if not most harm is triggered by variations within the domain of the ordinary. So it pays off to understand and be prepared to address ordinary variations. Another important consideration if accreditation should work for us, it's not a standalone intervention. It should be integrated into the organization's total strategy. We have a lot of other ways in which you want to improve and enhance quality and performance. You would have lean projects. You could use quantitative clinical quality indicators. You promote patient and staff engagement and conduct experience surveys. You might develop prompts or PREMs, patient-related outcome measures, patient-related experience measures. You may have an adverse event reporting and learning system, and a lot of other things may be going on. Integrate accreditation to all as a tool to support and promote all of this. A Canadian study showed that when a large number of stakeholders were asked how they believed that accreditation would be able to have a positive impact on quality of care, then three crucial factors emerged. Coherence, there must be an alignment between accreditation and the organization's beliefs, context, and model of service delivery. If what accreditation tries to get you to do is in conflict with what you are otherwise doing, nothing good will happen. There must be an organizational buy-in. We don't do this as a tokenistic thing, but because we want to do this as part of the way we work. And of course, there must be an organizational action. The organization must be able and willing to respond to whatever observations, feedback, or self-reflection results from the accreditation process. And then, as a leader, you must be brave. Avoid using phrases like, we must do this because of the accreditation. It's required for us by the accreditation body. Find the meaning in the standard or go back to the accreditor. Accreditation bodies are very competent, but nevertheless, there may, some hopefully very occasionally, be requirements in the standards that are less well considered, or maybe just phrased in a way that lends itself to misunderstanding. By giving feedback to the accreditor, you may contribute to the improvement of the accreditation program. So, no blind compliance, make sure that this is, yes, there is a reason for this. We can see the reason, we can communicate the reason. And be aware that accreditation is not regulation. In particular, a program with stretch standards does not describe something that you must meet, but something you strive towards, but it may not be realistic to achieve everything right now or before the next survey. So you must also be able perhaps to accept a less than perfect assessment, but be aware that this is a journal, you're traveling a journal, a journey that will eventually lead you to the place you want to be. The most recently published systematic literature review demonstrated that overall results suggest that accreditation may have a positive impact of efficiency, safety, effectiveness, timeliness, and patient-centeredness, but there's less evidence to say something about its impact on access or of the equity dimension. Mainly due to methodological shortcomings, the positive impact of healthcare dimension should be interpreted with some caution. This may seem disappointing, but in my opinion, it reflects that accreditation can't be studied in the same way as a drug that is administered again and again under similar circumstances. Accreditation is a complex intervention differing from program to program and applied under varying conditions that affect the outcome in a multitude of ways. It's more like a tool. We can learn how to use it, but we must also always be prepared to adjust the way to a particular situation. We can learn from others, but you can't just copy from one situation to another. So to understand the impact of accreditation better, ISQA has a group of people associated with ISQA are preparing a white paper where we study 4 cases: Denmark, Australia, Botswana, and Jordan. And we asked the question, how were accreditation programs implemented and operationalized? What were the enablers and challenges when trying to achieve a positive impact? And this paper will be submitted soon to a peer-reviewed journal. So, when you enter an accreditation program, you go into a cycle of activities. Usually it's a 3 or 4 year cycle where you do a self-evaluation, develop a quality action plan to comply with standards. You have an external evaluation where you get feedback on your progress. If there's a performance gap, you get a report that provides you with information needed to close those back, and there may be a follow-up or a periodic review. If you meet the requirement to a sufficient degree, you will get an award that's valid for a certain amount of time, and there will be succeeded cycles for re-evaluation. To wrap up slowly with some important points, accreditation standards are not a set of prescriptions for action, but a tool for investigation of your organization. Accreditation is a mindset, not a task that you can delegate to an accreditation manager. Of course, an accreditation manager will probably be very useful, but it's the leaders that must lead the accreditation journey. Go for the learning value, not for the award. If you do that, I'm sure you'll get the award. Beware of over-implementation. Healthcare is a complex system. You can standardize many procedures, but you can't make a rule for everything and be sure if you just follow the rules, everything will be fine. Accreditation can reduce complexity, give you an opportunity for reflection, give you a common language when you talk quality improvement, quality control, quality management across organizational borders. It's a vehicle to spread ideas and best practices. It can give you a common understanding of priorities within your organization. And it takes a holistic approach across borders and across quality domains. Successful implementation will require commitment from the top, that you are able to tell the story of why, that you build and support involvement from the front line, that you don't overfocus on processes, and that you make sure that the survey is a learning experience, not an inspection. Just to mention this white paper, I think I related to it briefly before. It can be found on the ISQA web page, and it summarizes much of the concept of external evaluation or accreditation. And finally, just to mention briefly, we have a conference in October this year in Brisbane. All of you are welcome to register, and you will still have the opportunity to get registration at early bird rates. So, Thank you very much.
Muito obrigado, Dr. Carsten. A sua apresentação foi muito objetiva, muito clara, e ela será de grande utilidade para todos nós. Eu gostaria agora de, por alguns minutos, lhe propor algumas perguntas que nós recebemos das mais de 300 pessoas que estão participando dessa conversa. Aqui no Brasil, é muito comum hospitais pensarem que o processo de acreditação apenas pode ser feito em grandes hospitais, que pequenos hospitais, que médios hospitais não conseguem ou não podem fazer o processo de acreditação. Como o senhor responde a essa questão?
Well, my experience is that the accreditation is very useful in all sizes of organizations. I worked with accreditation in my own country, Denmark, for 14 years. And during the last of these years, our main focus was actually on smaller organizations, small private clinics, and even general practices, specialist physician practices. Of course, it requires that you have standards that are adapted to the type of organizations that they are intended to serve, but that can be done. The main way in which you work with quality, the basic foundations for working with quality, patient safety procedures are the same across the whole spectrum of organization sizes. But of course, you need to find an accreditation body that understands to phrase the requirements in a way that suits the type of organization we're talking about.
Há, em alguns lugares do Brasil, pouco de resistência por parte do corpo clínico diante do processo de acreditação. A pergunta é: como envolver o corpo clínico? Como envolver o corpo clínico neste processo de acreditação? E segunda pergunta, se essa resistência por parte de médicos é comum em outros países que não o Brasil.
Yes, this is something we see everywhere, almost everywhere. We saw it in Denmark as well. I think the only way to counter this is to be able to tell the story why we're doing this in a convincing way. And it's actually interesting to consider that this very first accreditation, more than 100 years ago, was actually initiated by physicians. And the purpose was to ensure, because that was in the United States where physicians were, and still, in many cases still not, are usually employed at the hospital, to ensure that the hospital was a suitable place for a physician to treat and care for his patients. One of the challenges is that accreditation often does not go so much directly into what the clinicians see as the core quality issues, the quality of the services directly provided, but more like what is surrounding many of the surrounding things. But first, these things are important in order to be able to deliver quality. And one of the things that I have found catches the interest of physicians is when you introduce clinical performance indicators, as many accreditation programs do. Collection and discussion of clinical quality indicators, especially if you can convince them that this is not to punish bad performers, but to help everyone improve, is something that will engage physicians.
Outra questão envolve a relação entre governos e os processos de acreditação. Fica muito claro na sua palestra que a acreditação só pode caminhar se ela for uma convicção do hospital. Agora, os governos podem estimular, podem apoiar, podem ser indiferentes. Aqui no Brasil existe muito a crítica de que o processo de qualidade é um processo que recebe pouco estímulo e pouco reconhecimento por parte das autoridades. Eu agradeceria um comentário seu sobre esta questão.
Well, there are several ways of doing it. In some countries, there is a distinction between what you could call regulation, making sure that hospitals meet minimal requirements, and accreditation that is then viewed as an overarching as a way of promoting quality improvement. But in other countries, they are trying to find ways to integrate the two. I think one main thing is, well, in a way you would put it in this way, the public hospitals are led by public authorities of some kind, and they are the leaders in just the same way as the board is the leader of a private hospital. The top management must have and demonstrate the commitment and actually act in precisely the same way in a public hospital than they would in a private hospital, I think. But of course, in some aspects, what would you say? It is, of course, it's of course difficult it can be difficult for a public authority to take hard steps upon a public hospital, because it has also the duty to serve the population in a given area. But I think, and it's my experience, that accreditation is useful no matter what sector you work within, as long as you are clear about what it is and why you're doing it, and that you treat it as a tool to promote quality improvement.
Gostaria de um comentário seu sobre experiências mundiais de países em que a acreditação ganhou um impulso muito grande. Normalmente, quando se examina a questão da acreditação, se identifica muito com países como os Estados Unidos ou outros países europeus, todos eles muito desenvolvidos. O senhor apontaria exemplos de que o processo de acreditação começa a ganhar força em países não tão desenvolvidos?
Well, there are a number of examples. First, there are examples in Brazil, but then there's Malaysia, India, South Africa, just a couple of examples. Thailand are countries with well-established accreditation programs that have been in existence for many years and have contributed to development of quality of services in their countries.
Dr. Carsten, nós devemos agora encerrar essa conversa muito agradável e eu gostaria, em nome da Anahp, de cumprimentar a ISQA e cumprimentar o senhor pelo trabalho que realizam. Desejar que aqui no Brasil nós possamos, como lhe disse, impulsionar mais e mais o trabalho em favor da qualidade e lhe desejar que receba um agradecimento muito especial pela sua disponibilidade, pelo seu tempo e pelas suas lições. Agradeço ao senhor e passo para os seus comentários finais.
Thank you very much for your warm words. It has been my pleasure to talking to you, and I really hope that I have stimulated some thoughts in you. And if you have any questions regarding accreditation, you can of course go to your Brazilian accreditation companies, but you are also welcome to reach out to us, and we will help you in any way we can.
Muito obrigado ao Dr. Carsten, muito obrigado às mais de 310 pessoas que participaram, foi o nosso pico de presenças. Muito obrigado a todos e nós, como disse no início, esse não é um evento sobre qualidade, esse é parte de um movimento em favor da qualidade. A Anahp não está satisfeita com os números que existem no Brasil. Nós podemos mais em matéria de qualidade. E o objetivo da Anahp, em parceria com a Walters Clover, que nos apoia neste momento da jornada de qualidade, com as empresas e companhias acreditadoras, o objetivo é disseminar ao máximo as razões, os porquês, como disse o Dr. Carsten, as razões que devem motivar os hospitais a, em nome do paciente, em nome da qualidade e da segurança, chegar à acreditação. Insistimos nisso. A acreditação não é uma estrela colocada na porta de um hospital, como de um hotel. A acreditação é uma profunda reflexão que um hospital faz sobre o seu compromisso, a sua estrutura e a sua relação com os pacientes. Muito obrigado a todos. Obrigado, Dr. Carsten.
Goodbye.